The next level clinical interventions I want to talk about are supplements. We use supplements in a targeted format. I'm not a big advocate of just sort of blindly prescribing supplements. Our concept is optimal nutrition as the foundation, supplementation as needed, and I like to say it, Foodaceuticals as a foundation, Nutraceuticals as needed, and pharmaceuticals as last resort. And sometimes that's reversed because they come in on lots of pharmaceuticals or they're acutely ill, but that's the general concept that we like to apply. So what are some foundational supplements that we use? We start with actually superfoods, and these are not necessarily classically supplements, but actually they're really foods. We use blue-green algae, we use freeze-dried powdered greens. Sea moss is an example of a sea vegetable that we like to use, that other sea vegetables we recommend. We use a lot of methylsulfonomethane as an elemental sulfur, which helps reduce inflammation, reduce oxidative stress, helps in the production of glutathione. We utilize liposomal vitamin C. It's very readily absorbed by our patients, especially our patients that have cancer and other chronic inflammatory conditions. We use liposomal curcumin as well as a liposomal Q10 for our heart failure patients. So basically, these supplements are used to reduce inflammation and oxidative stress and enhance cellular function. So medications, clinical intervention. So how do we manage medication? So I like to use the term optimization and weaning of medications. My personal thinking on medication that we used to need to reduce their use as much as possible, because medications can have adverse side effects. Yes, they have a benefit, especially in the acute setting, but I like to use them for short term at most while we're trying to get the patient an optimal nutritional balance. And so we start off by looking at the medication list. It's not unusual that our patients have maybe 30, 40 medications, and we try to remove or wean all unessential medications. So we start with non-prescription medications, over-the-counter vitamins and supplements. Diuretics often used in patients for mild symptoms of swelling and the like. We try to reduce or remove these. Oftentimes these, of course, cause dehydration and deplete essential electrolytes such as magnesium and the like. We reduce insulin on patients, especially if they start a nutritional detox program. We may have someone on 40, 60, 80, 100 units of insulin a day. We will then reduce it to 0 and put them on a sliding scale, a simple sliding scale, to where they only take a certain amount if the blood sugar is above a certain level. After week 1, we see them follow us. So in the nutritional detox, we typically see patients 1 week apart, especially if they're on lots of medications and they're undergoing a detox regimen. We see them at least weekly, sometimes more frequently than that. So after the first week, we typically look at diuretics and try to wean the remaining diuretics. We look at other types of medication, antihypertensives, and we make adjustments in these medications based on their blood pressure response to detox. And then, of course, we look at other things like proton pump inhibitors, NSAIDs. If they have severe arthritis and it hadn't responded within the first week or 2 on the nutritional detox, we may put them on, let's say, a liposomal curcumin to help with the symptoms and allow us to wean the NSAIDs or steroids faster, of course, inhalers and the like. So again, we continue to make changes in the medications and wean them as rapidly as possible, because the weaning and reducing and simplification of the medication list frequently enhances the overall clinical response. And we see this as important of an approach to their condition as anything else that we do. And so in our situation, we tend to take control of all of their meds. Even though we are a cardiology practice, we do manage the blood sugar and the blood sugar medications and other medications as well. So what are some of the more invasive interventions that we do? As I said, sometimes we have to do things that are much more invasive in the office, intravenous infusion. We do vein ablation therapies and the like. And then, of course, hospitalizations for chronic, for the acutely ill patients. We may have to take them to the cath lab, or, some of our patients do need surgery, but it doesn't replace our natural nutritional intervention. It is an adjunct to, and I'll share that with you in some of the clinical examples.